All right, good afternoon, guys. How's everybody feeling after that scrumptious lunch? You feeling good? Thumbs up, high five. All right, that's the spirit. Very, very good. Welcome back, and thank you for those of you who made it over to take our picture. You will definitely be able to find that on social networking under Health 2 Conf, so please feel free to look for that in the coming weeks. Add it to your collection of your Las Vegas photos for December 2023. Little quick announcement, guys. If you've been looking for an excuse to travel to Dubai, who hasn't, right? That's personally a place on my bucket list. Great news for you. Global 2.0 Health Conference is going back to Dubai. Wait for it. May 1st to the 3rd, 2023. We would love to have you there. We are currently looking for sponsors, exhibitors, delegates. If even a small part of you kind of got excited by hearing about Dubai, I want you to get your pen and paper out and write this down. I'll give you a sec. You are going to contact, for more information, one of our VIPs here at Infinium Events. His name is Jatin Sidhu. In fact, you'll probably meet him at the end of the conference. And you are going to reach out to him via his email, Jatin, that's Jatin, at Infinium, infinium.events. And that's how we roll here. I'm just going to give you the information straight. You can contact him and see if it works. We'd love to have you and see you in Dubai. If you're like, well, Melissa, I'd love to continue the networking and, meeting other awesome colleagues in the industry, we're coming back to Vegas also next year, and that's actually going to be July 10th through the 12th, and you will also reach out to Jatin for that. Again, whether you want to be a speaker, delegate, sponsor, we'd love to have you. And I'm going to give you Jatin's phone number for this, and you can contact him via email or phone number for both events, both locations. His number is 424-320-3090. I promise I had I got the okay to give out his phone number. I'm not just spreading out his number. Okay, guys, let's further ado. Let's hop back into it and get our thinking caps back on for all of the great knowledge coming our way. Next, our panel discussion on high time for collaborations, collecting and sharing population data to understand gaps in care. This conversation could not come at a better time, as new evidence suggests that when communities, businesses, governments, and citizens collaborate on population health data collection and sharing initiatives, improved healthcare outcomes follow. Makes sense, right? Today, we are fortunate enough to have an esteemed panel of experts from various disciplines and geographical locations who will share their thoughts on this subject. I invite next the session's moderator, Tucker Owen Marcheso, who is co-founder of XYGene, to come up to the stage and begin the discussion. Round of applause for him.
Tucker Marcheso, beautiful Coeur d'Alene, Idaho. Many of you have been still from there if you haven't. With you is a wonderful panel. I had the pleasure to meet prior to this engagement. So I'd just like to take a quick minute and have them introduce themselves. Well, my name is Tucker Marcheso. I'm with XYGene. We are a collaborative approach to try and get laboratories, pharmacy, and providers all to talk at point of care. I like to say we are all points of care at point of care. So that is about would like to have to begin.
Yeah, sure. Thank you, Tucker. So thank you, Tucker. I'm very honored to be here. My name is Hanna Dantata. I'm a co-founder and managing partner at Health Maxima. Health Maxima is located in Gaithersburg, Maryland. We focus on global health, public health. We implement in Africa, Asia, and I'm looking forward to sharing our experience. This is a very interesting topic, especially given the experience we've had with COVID. So I'll just pass on to the next speaker. Please, thank you.
You guys hear me?
Yes.
Okay, I'll just stay here. So my name is Neel Butala. I'm a cardiologist, but I also co-founded HiLabs. I'm the chief medical officer there. Essentially, what we do is we refine healthcare data to enable organizations to do cool things with it. Essentially focusing on data quality, and that's a huge problem we see in all the hype about interoperability. So we're happy to talk about the problem and then solutions and how we can actually solve this problem together.
Pleasure. Can everybody hear me? I'm Dr. Scott Martin. I'm by training, a board-certified interventional pain doctor, but for the past 9 months have worked as the vice president of clinical development at Regenetive Labs. We're a human cell and tissue company out of Pensacola, Florida. We are probably the only company that's amassed the amount of clinical data in the biotech space. We've collected over 240,000 data sets on patients in the past 4 years. We like to say that we are essentially the Cochrane database of the biotech space. I am responsible for all the clinical trials, a lot of the clinical research, the publications, and novel homologous uses for the company. We are actually a very robust tissue bank. We're from point of collection to point of care and everything in between. And sincere and humble pleasure speaking to you all today.
Good afternoon. My name is John McCabe. I am the founder of Sustainable Six Sigma, and our focus is on people, process, and efficiency. The company believes that you cannot blame someone who was put in a bad overall position for their failure in the actual enterprise itself. You always must pause, stop, and evaluate the underlying process and move that person to the position where they're best suited for. Thank you for your time, and I look forward to the panelist discussion.
Fantastic. I will leave a little bit of time for people to ask questions. Just as a reminder, if you have some questions, try to get up to the mic. I like to think about interoperability as everybody trying to eat alphabet soup with a fork. When you get it from one point to the other, you don't get the complete picture. You don't get that full bite. You don't get all the information. One of the things I think is going to be really important that we're going to talk about today is, as everybody's talking about the interoperability, I think a great place to start is the quality of what's being moved. So as that data goes from one place to the next, how do we ensure that quality of data? And why don't we start with Dr. Butala? Let's start.
Yeah, thanks, Tucker. So, I'm a physician. I take care of patients. I document the medical record, to take care of my patients, not to feed into some population health algorithm downstream. Right? I care about documenting to help people, not necessarily to fix in some formats. Unfortunately, what I document does get turned into some standardized format through an interface engine, gets transmitted through an information exchange to another entity in healthcare, who then tries to use that data, which is not the purpose of me generating that data. So fundamentally, there's a disconnect between the generators of data, whether it's clinical data like what I generate, claims data, which sometimes providers generate, others generate, provider directory data, value-based care data. There's a number of different types of data that essentially generates in entities that are designed to produce that data for their own operational or clinical uses. And with new regulation, all this excitement, there's a lot of transmission of data from one entity to another. And again, goes through an interface engine, gets reinterpreted in another organization's context. And that fundamental process of transmission from point A to point B, the promise of interoperability exists in that transmission, but unfortunately, there's a lot of data quality issues that happen. Essentially, it's like a game of telephone in real life with life or death things at stake in terms of data quality. And so what we've done essentially focused on using machine learning to essentially detect anomalies in that data and solve that problem. So help communicate to different entities when data quality is an issue. So essentially, we sell primarily to health plans, so we will deal with 4 to 10 largest health plans in the country. They pay us to essentially help them make their health data better, whatever it's coming from, whether it's providers, whether it's other payers. And essentially, using machine learning as an opportunity to detect anomalies in this data come from disparate sources, to then make it usable for a downstream entity. And happy to talk about the details of that, or essentially the magnitude of the problem, and then ways to solve it. But essentially, data quality is something that I feel like is almost underplayed in this discussion about interoperability and ways to solve it.
So it's interesting. We, as a regenerative medicine company, when we have been treating patients, and I was in pain for 17 years. If any of you are medical or even around medicine, you all are very aware of this notion of pain being the 5th vital sign. You're also very much aware of the narcotic epidemic that closely followed that. We were all chasing data. That's what we're chasing. Patient walks through the door and they say that their pain's a 6. Just that simple statement, my pain's a 6, which is a completely subjective statement. There's no objective way to qualify that. Set an entire cataclysmic group of events in motion. that was all middled, unfortunately, by all sorts of folks, all with their own, at times, unsavory goals. This transmission of data, right? As a provider, having seen 10 to 12,000 patients a year for 17 years, we are left with basically an untenable burden. Health plans want what they want. Patients want what they want. To satisfy medical boards, they want what they want. And all the while, you're trying to just make a living. It's really terrible from a provider standpoint, because there's no uniform way to collect data that satisfies every entity. And it's a travesty. Point in case. In over 240,000 data sets, we as a company were able to show improvement in pain in a significant degree with our allografts. We found a 4-fold improvement in function. You can walk into any hospital, office, medical center, ER, and you will never get asked in the triage area about function.
And speaking of standardization, if you wouldn't mind, Mr. McCabe, if you wouldn't mind talking about what is the importance of potential for standardization inside of this data?
I think one of the first things we have to do is pause and understand how we are actually collecting this data. What is the quality of the data we're collecting it? How are we collecting it, and where are we collecting it? Do we, dare I say, go so far as saying, do we need a national data collection standard so everyone is following the same set of standards, so we are going to get the same output downstream?
How do you think that affects public health?
So it's interesting you said that. We were actually just having that conversation, because I'm coming from the angle of public health, and I'm really actually in the management, from the management angle, where we, in the past 2-3 years, dealing with COVID, we had to work with 55 member states, especially in Africa, work with Africa CDC, work with multiple stakeholders to be able to track data, and did epidemiological reviews and came up with ministerial briefings that we provided countries. So with that, we were able to observe how those data differ from country to country, given the political dynamics and many, many factors that affect that developing world, which is very different from what my colleagues are talking about, where, we're talking about machine, enhancing how data is captured, and how we're talking about countries that are even just trying to set up that. In Africa, where they're just trying to set up that platform. In some places, those platforms are not even existing. So you have to work with the very traditional method of collecting data. So it's interesting how it's similar in the sense that we also need centralized system. We're discussing that with those entities. But in this dynamic, it's also, there's a need for that when you're talking about a more advanced technology or developed countries. Yeah.
Agreed. Standardization would be a miracle, right? If we could all get something that was uniform that we could all pull from. When it comes down to quality of data, what do you think is important as we're going towards a potential standardization model at some point? That the quality of data, how does that play into the standardization model?
Yeah, and that's a great question. Happy to hop in there. So, standardization would be amazing, right? I think it'd be very hard to implement. Certain segments, certain types of data can be standardized more easily, like ICD claims, right? You have a coding system of how you have diagnoses, procedure codes. That's something that's a very standardized type of data in healthcare. A lot of other types of data is going to be very hard to standardize, right? So even for physicians, like pain scales, very hard to standardize across different types of providers, different settings, inpatient, outpatient. Different people, responding, different people interviewing. So I think it's going to be very challenging, but essentially I don't think it's a hopeless endeavor to attempt standardization, at least where we can in different segments of the healthcare industry. And then to meld it together and transmit it, I think we will need some sort of technology-enabled solution, whether it's someone aggregating that data and then standardizing it, post hoc, whether it's active real-time surveillance for data anomalies, which is something that our company does, whether it's people receiving the data ultimately deciding how to decipher it. But ideally, a standardization mechanism up front would be the cleanest, the best. I think we have to have other avenues to approach it should that not come to actualization. And I think we have a variety of perspectives here on that. So.
And I think really it can be broken down into 2 or more parts, right? Standardized data that is non-tangible, and then standardized data that is tangible. And if we start with standardizing data that is tangible, we'll have a better pathway towards standardization in the long run, right? And also really help and address underserved communities and populations by providing them the tools and techniques that they need in order to raise up and have the proper technology.
So there's a chasm. There's this purgatory that I see the United States in. It's interesting, there was some talk from Medicare in 2026 looking to move all Medicare care to prior authorization, which I think is a movement towards that standardization. But if you look at the way medicine's practiced, we've been in the profit center practice of medicine for well over 50 years. And we've been kind of shooting and aiming for an outcomes-based measure of medicine, thinking that that is kind of the panacea, that's the holy grail. It's actually not. The ultimate is really value-based delivery of healthcare. Because if you take simply a radiology read, as long as you're quantifying the number of findings on an MRI and you're scaling reimbursement on the number of things documented, you're going to have overread MRIs, which are ultimately going to lead to unnecessary surgeries and everything else. That's again, value-based, profit-based medicine. Outcomes-based medicine is completely different. It's looking at objectively, the research patterns, publications, evidence-based medicine, and then determining what we can learn from all of this profit-based medicine. But way out here, that's going to need population-based aggregation, that's going to need AI-based aggregation, that's going to need eventually standardization, is going to be value-based medicine. How do we pay a living wage to providers who've got $300,000 in student loans and at the same time not have this massive chasm in care between somebody who walks in and can, with a check, get the very best surgeon in any state or any locale they're in and walk ahead of 30,000 people waiting in line just to get an ultrasound or just to get an EKG. I did training in Royal College Hospitals in London. There's a caste system there. We're moving towards that in the United States. It's basically people who can pay for private care and everyone else. And as long as we're stuck in this middle road between profit-based medicine and outcomes-based medicine, and we think that somewhere eventually we're going to get to value-based medicine, we're going to turn into a caste-based system.
In the public health center, how does that issue affect places that can't necessarily attach? Maybe they don't have the technology, maybe they don't have the machinery, maybe they don't have the connectivity, interoperability between those things. As these things become standardized and the world's moving faster with technology all the time, what is the importance of updating? So when somebody switches the system or gets a solution, that solution often means that you're now 24 months into trying to relearn that solution, getting that solution to work with the last thing you were working with. How does that affect public health?
So this is a really good point that you're raising, and that signifies if we're having problems here and we're trying to get, like he said, from this profit-based dynamic to a value-based, and these are discussions happening in developed countries. You can imagine in developing countries, all that reporting that you see about how there's very little support system for countries, developing countries, in terms of tracking, in terms of even the data, validity, reliability of the data. So you can't really gauge when there's a disease or there's a problem, or in this case, epidemics, what we dealt with, pandemic, COVID. You can't really gauge what is being reported is really representative of what, the country that you're trying to review, or the platform, or the facility that you're trying to track. So there's so much death that is unaccounted for. There's so much diseases out there that are unaccounted for. So, those are the challenges, and that's why that funding and that support system, there's a need for that still in developing countries, because we don't have those platforms yet. It's like two different worlds. But from country to country, like I said, you can see progress being made, where investments are made in some countries, where you can see platforms. Some people, individuals, investors, or even people in the diaspora from countries in Africa are going back to begin discussion, or start putting investment in platforms that can grow into what we need it to be, and capture what is needed.
So I work a lot in the long-term care space. I feel like the same kind of issues that you're bringing up from those very disparate systems, or some that don't really even exist, in a lot of our long-term care organizations, those mom and pop places typically can't connect. And during COVID, I recall that even patient advocacy groups couldn't get in and take care of those patients. And so when the physical presence can't be there, and the time that is needed for a person or representation for those individuals to be in front of the patient, what can take over? And I think interoperability is a really good point of this. Where can technology start to implement when the human element can't be present?
I understand technology is a very important part of all of this. But I also think we have to consider the point of having a mind shift change from having a healthcare system to a well-care system, where physicians are rewarded to keeping their patients well for the long term and being rewarded off that, and not taking care of them only when they're sick.
Well, that's in complete contrast to the way most health plans run and most HMOs run, right? You're getting reimbursed and you're getting bonused for providing less care, for taking more on you. The whole Atlas Shrugged model is in reverse.
Right.
You've got a primary doctor who's very well trained, but at no point is he going to have the training of a nephrologist or an interventional cardiologist, and he's expected to now not refer a patient that he may or may not have felt a lump on in a prostate exam, or not refer a patient who's got, potentially silent heart attacks or maybe anxiety attacks, and he's not expert in either of those, but he's got this big financial incentive at the end of the year if he doesn't refer those patients out. You're in long-term care. You can't even treat a pressure sore until the skin's open. There is no treatment for stage 2 pressure sores. With so many people now transitioning over the age of 50 and 60, 70 into long-term care facilities, how many dollars are we going to throw at big open wounds after they've opened? It's just terrible. It's terrible.
And so building off what you said, though, I agree. I think in general, my bias is all doctors mean well. We all care for our patients. We want to do the right thing. And I think there is potential, though. I don't think it's all doom and gloom. I think the system is set up to where there's a lot of incentives structured to where it's challenging for a primary care doctor to then guide care if they're not informed. But I think that's where technology can play a role. If you inform the primary care doctor, whatever doctor is that serves as a gatekeeper, or at any clinical decision point, if that doctor or whatever provider it is, even it could be a long-term care provider, is informed with the appropriate, whether it's context around the patient's risk, whether it's existing data from other sources, whatever it may be. I think if the clinician or whatever kind of provider it is who's making the decision as properly informed, I think it actually can lead to decisions that ultimately, down the line, can reduce costs and improve care. So I think fundamentally there is an opportunity for technology to play a role there. Again, it's idealistic and a ways away, but I think it still exists. And I don't think I think we're a different state now than we were 20 years ago when HMOs initially came out, where we actually have the ability to provide data and feedback to primary care doctors, whoever. We're not quite there yet in providing that appropriate information at the time it's needed, but I think we're able to shorten the time to which practitioners have feedback on the types of clinical decisions they make to then enable these types of decisions to improve health systems overall. So I think we're a different spot now than we were 20 years ago, but there's still room to go, and I think technology is fundamentally going to be something that enables that transformation. But if that technology does not meet that demand, then and people aren't thinking about the right technology or data problems to solve, then I think we're going to repeat the same problem we did with HMO. So I think there is hope still, but I think there's a need for a technology-enabled solution to sort of exchange data and provide data at that point of care. And maybe Dr. you can speak to that or others.
I think that there is, where I find my passion is around time. I think that the currency that we talk about, especially with the providers, especially in the pay-in-place system, if you will, one of the biggest issues that my company works to tackle is I want to give providers enough time to do the work that they came educated to do. Provider burnout is a real thing. You can pay them a lot of money and they can still get burnt out. I think that being able to have appropriate interoperability from quality data sources that are going to be delivered in a way that is integrated is going to be the future. The real question is how much time can you give back to a provider? You can have the greatest technology in the world. If that technology doesn't get adopted, it doesn't get utilized unless it has a functional element. That functional element really comes down to time. I want my doctor, I want my nurse, I want my healthcare provider to be able to go home and practice the life balance. And technology, I think, is going to be the way forward to do that, because I am a bit more of a pessimist in the fact that I don't think that the United States is good about getting out of a pay-to-play model anytime soon. And because of that, if I can't pay them less, they may not be able to pay them more. But we can work on giving them time back and make relevant solutions with more of a collaborative approach, which I think is really the impetus of what we're trying to discuss here. Is what is the point of that interoperability? The point of that interoperability is to let precision medicine happen. Precision medicine for value-based care is kind of the forefront of what we're all working towards. I would be curious from each of you is, where do you think data is going? So as all these places of interoperability is happening, where do you think that drive is going to go forward with in the near future?
I think good, clean, quality data is going to become more and more expensive to obtain because it's going to drive better results for the people who own the data.
I'm very much a pessimist. I got sued by Bayer personally. I'm a very big pessimist. Here's what I think. I think if we took the best models in the country, and you've got Intermountain Healthcare, and you've got the VA, and you've got Kaiser Permanente, and you've got Sharp, and some of these really MD Anderson, Mallinckrodt Institute of Radiology, and Washington University in St. Louis, and Mass General. We don't work backwards in medicine, and we never have, because so many people look at the pie and they're trying to figure out how they can get their piece. But we all know the cost drivers in medicine. They're not hard. The cost drivers in medicine are really pretty simple. And if as a community, we took data and we worked backwards from the cost drivers in medicine, and we put very clean channels of communication in place to get those patients that were at highest risk for diabetes, at highest risk for cardiovascular events, at highest risk for GI issues, at highest risk for amputations and peripheral vascular disease, all of these major cost drivers, And we gave the patient some incentive. We're all talking about how we're going to give providers incentives and health plans incentives and insurance companies incentives. What's the incentive for a patient to go out and spend $7 on a salad when they can get a large fry from McDonald's for $1? What's the incentive for the patient? And I think we got to that a little bit with telehealth. We made it convenient. I'm sorry, when gas is $6 and $7 a gallon, if I don't have to go drive to the provider and you're going to bring medicine to me, that's a pretty tasty incentive. But if we can't figure out how to wrap those incentives and establish behavioral micro wins for patients in their own homes and in their own lives, we're going to be spending a half to a third of GDP on healthcare forward going forever.
I'll end with this last question because I want to make sure that there's going to be time for questions. I think that we've all kind of touched on these data points, how they interoperate. I think that one of the things that my view, and maybe shared view, is that outcome data is really what's being pushed after the fact. They died. They now have that open, they have those things. So the prevention, which I think that interoperability should be the forefront of, how can we get that information delivered ahead of the care so that the provider has the best pattern for care. So that they can spend the time not navigating and clicking between different screens or different websites, whatever web scraping that they're doing. I'm sure most of you are probably scraping from somewhere. How is that outcome data driving current solutions?
I mean, I don't think I'm the expert to answer that question, given the dynamic of what my colleagues have just brought up now and being expert in that. But what caught my attention, which may be linked to what you're asking right now, is that there's so much similarity, again, in terms of everything that he mentioned about how all this is driven by funding is so key. Whether it's private sector, where you have funding which will raise the cost of what the end consumers will be paying more, or we're talking about the government funding raising the budget for the country, is the same thing that we face also in my own field of work, which is international health, where this is the major issue in terms of data management, data that we want from countries, the existing structure that we want. We need it so bad, but it's driven by funding. And especially in developing countries, we don't have the funding coming from the population. It has to come from the government sector or outside donors, and this is a key challenge. So that's just my contribution to whatever it is that you're asking on data.
So building on that, though, I think maybe something a little bit different now, which I do feel like there's enough large players investing in this type of information technology to get, whether it's technology solutions to enable data to be useful for entities that are actioning on things, or whether it's just enough people investing and having enough dollars pushed on them to invest in population health at a large corporate level, or whether it's a large nonprofit level. I think there's enough dollars invested in this space right now, which is very, and a lot of people actually genuinely mean well with those dollars, and the incentives are structured to where, if they succeed in using technology to make that data interoperable and useful, they will succeed financially, to where I think the incentives may be structured to where it can be more successful than in the past. So I feel like there's enough smart people thinking about innovative ideas and how to approach that now, at least in the US. So investment is key, as you're saying, and I think there's enough corporate interest in it, at least in the US, by my perspective.
I'd like to open up the floor to any questions. If you have questions, please either raise your hand or step up to the mic. And I have lights in my eyes, so I might not be able to see you.
Sure.
There we go. Thanks. Thanks for the panel. Really, thought-provoking stuff going on there. Two issues seem to come up again and again, and I think there's a little bit of an elephant in the room that wasn't mentioned, and I want to know the panel's thoughts on it. One thing that's mentioned over and over is quality of data, right? And I'm a pediatric oncologist, and we can get some really nice stuff coming out of countries with universal healthcare. The other thing that had come up in the discussion was really kind of reimbursement rates and pay-to-play systems and all that. It seems like universal healthcare may be a solution to both of those, and what's the panel's thoughts on that?
We'll just go down, starting with you, John.
When we talk about quality and quality of data, I think we really have to go back and define and understand what does quality mean to us as a whole, as a country, and start from there and say, okay, this is the best system or model we have. This is the inputs that we need to have the cleanest outputs. And then from there, take that system or that economic model or that healthcare model, and then share that with the rest of the major healthcare systems. And then from there, cascade it down.
I can only speak from experience. I did a year of medical education in England, and you had to discuss the 23 things that a patient didn't have by looking at their hands. Patient didn't get EKGs, they didn't get ultrasounds, they didn't have labs. It was very clinical medicine focused. And we have gone so far past the Rubicon from the clinical practice of medicine to basically the objective defining of illness, right? I can't tell you what you have until I get the MRI report. I can't tell you what you have until I get the biopsy back. I can't tell you what you have until I get the path back. Mm-hmm. Clinicians aren't clinicians anymore. We're basically just test takers, and we deliver information. 50 years ago, there wasn't, a readily available MRI or open MRI that you could get into on Saturday at 2:30, over an extended lunch break. Because of that availability, cost has been driven up, but I think quality of care has come way, way down. I think if we're going to get ultimately to better delivery of medicine in a prevention-based model, I think it has to be done with less and not with more. I think we have to go back to basics. Part of that is exactly what you said. You have to listen to patients. Patients will tell you what's wrong, but you can't find out what's wrong with a patient in 6 minutes.
Going back to a little bit what you said about data quality coming from universal healthcare systems, I think there's something to disentangle there. At least in cardiology, we have large national registries that are actually pretty good in terms of data quality, so much so people run randomized controlled trial through some of these registries. So I don't think a universal healthcare system is necessary to have high quality clinical data, at least in specific disease states, which people invested in, whether it's nonprofits or other industries. That being said, I don't think universal healthcare on its own is sufficient to have good data quality. There's large national health systems, even the US, where data quality isn't amazing if you just look at the general data people have. So I think these two issues may be a little bit separate, certainly related, but one doesn't necessarily apply to the other. So possible to do either one. Happy to chat more in other spaces.
Yeah, so data quality, like you said, I don't think there's much connection between it and universal health, because universal health, you're talking about ability to provide that health care for everyone, affordable. And with that, if you say you're doing that, there's the likelihood of compromising the quality, because then the funding of it will probably not be as good as. So that's the issue with the again, the private funding, where it drives more quality, but then it's not accessible to all. About again, what was brought up if you're making comparison with other countries, it's interesting because preventative care is really all there is in developing countries, right? When it comes to diagnosing diseases, really that patient one-on-one communication is very key in extracting and identifying what is wrong with the patient. So on the contrary, they don't have the equipment and the tools to quickly, in many countries, in many parts of many countries too, in developing world, they don't have those tools to quickly, diagnose the way we do. So it's interesting that we're losing on touch with patient while we have a lot of advanced equipment. But on that end, there's that touch with patients, but then you're not able to still provide good quality because you don't have the tools that we have here. So there's always a win and loss situation. So how do you create that balance where you have the best of both? That's just
So my answer is really quick. I lived in multiple countries with and without. I think that there's room for both. And I'm happy to elaborate if anyone wants to talk after. Yes, sir.
Hi, Eric Durack from Medical Health and Fitness, and I come about this whole outcomes thing from a totally different standpoint, health and fitness. And I got about 100 questions, but I'll try to just whittle it down to one. When you talk about quality of care, EMRs, claims data, all this other kind of stuff, and what might be the sort of the highest quality of data. I recently came across a company called HealthPoint Solutions in Austin, Texas, that has data that they can sort of deliver millions of data points in a matter of seconds. And my question is that the type of sort of quote data solution is something that is very all-encompassing, but can also get it done very quickly and give doctors and clinicians the answers they need in a relatively short period of time?
Go ahead, John.
So I'll be happy to take your question offline, and I'll answer it now too. There's several companies out there that do the same service, and they seek to they're fed multiple data streams 24/7, 365 into their massive data cloud. They're able to parse it, slice it, and dice it any way you choose, and then you pay for that service on an ongoing basis.
I apologize. We really want to answer all the questions, but I'll tell you this, is that the two middle panelists will be leaving today, I believe. So if you want to try to catch them right afterward, please do.
Yeah, I'll be here till tomorrow.
The other three of us will be available, so we're happy to take those questions offline. Thank you all for your time.